Good morning, ladies and gentlemen. I would like to thank Andrea for this kind invitation in this intriguing meeting. And I am the last effort before lunch, so I will try to be very synthetic and to give you the most relevant information. So this is a very ancient question, if giving LH can improve something in terms of pregnancy rate. So we are in the era, or we were, I don't know, of a meta-analysis, and despite I do not support so much meta-analysis, I tried to give some reply considering the level of evidence that we have at this moment. So please keep in mind, this is what I would like to consider, that if we want to interpret information available about LH, we have to consider that the rule of LH is totally different in different phases of folliculogenesis. In the early stages of folliculogenesis, the classical two cells, two gonadotrophin models is still valid. So we can consider that LH is mainly involved in TICA cells in inducing androgen production. Inducing androgens means that we induce the expression of FSH receptor. So probably if we consider the use of LH activity at this stage, we can consider the possibility that the follicular recruitment can increase. In the second part of the folliculogenesis, we can consider that the two cells, two gonadotrophin theory is overcome because LH receptor is also expressed by granulosa cells. And this has been very elegantly demonstrated in frozen ovaries recently by the group of Klaus Sieding Andersen. What we can say is that when follicles reach 10, 11 millimeters in diameter, they also express LH receptor in granulosa cells. And at this stage, LH is not crucial for follicular recruitment, but cooperate with the FSH in sustaining dominant follicles in all their functions. So you can consider that at the granulosa stage, LH and FSH, despite having a different receptor at the post-receptorial state, probably cooperate for the same aim. So it is important to consider that if LH is not so well working on this kind of follicles, probably we need to counteract, to balance this problem by increasing FSH or adding some LH. So this kind of information is important to understand that when we consider studies about the use of LH, we have to consider at what stage LH has been used and what was the aim of the study. Anyway, we have very few information about the use of LH for increasing recruitment. So given that the topic I have to address is pregnancy rate, we don't have sufficient evidence to talk about this when we talk about the priming of LH for increasing follicular recruitment. We have some more information when we talk about the use of LH during folliculogenesis, about LH, so-called LH supplementation. And this is very schematic representation, is just to give an idea about what is the behavior of LH during spontaneous natural cycles. What happens to LH during generate agonist cycles? LH is very low, and the fluctuation of LH that we have during stimulation when antagonist is used. So for the follicles, we have dramatic changes respect to the physiology of LH, but despite this, monotherapy with the FSH is sufficient to guarantee adequate folliculogenesis. So the only hypothesis is that LH is important, but if we have an apparently abnormal LH environment, the use of FSH is enough, is good to compensate, to counteract this kind of problem. So starting from this kind of a consideration, let's move to the clinical studies. So the ancient questions are always the same. Who requires LH supplementation? All patients, only patients in advanced reproductive age, some groups of abnormal responders. We can consider a pharmacogenomic approach and the use of LH in antagonist. And so I will try to address rapidly each one of these points according to available literature. Just to give a key of interpretation, I mainly choose studies with the recombinant LH for two reasons. Independently of clinical efficacy. The first is that is the topic in which I have direct experience in terms of research. And the second is that independently of efficiency and efficacy, I think that independent administration of gonadotrophins and the possibility of giving LH activity pure is the best way to understand which is the role of LH during stimulated cycles. So let's go to the first point. Do all patients, if we give additional supplement, if we give exogenous LH, in this case recombinant LH, in all patients, do we have any advantages in this? So let's move to the literature. This is what happened until 2006, because please consider that historical studies about the use of exogenous LH have been performed until 2006 and 2007. A few studies have been produced later on. And at that time, we had a few prospective randomized trials that had been analyzed in a subsequent meta-analysis that has been published by the group of Griesinger and Kolibianakis. And what they demonstrated is that adding LH, recombinant LH, during stimulation do not improve ongoing pregnancy rate in unselected patients. So if we consider the total population and we add recombinant LH at the different doses during both agonist and antagonist cycles, the conclusion is that we do not increase ongoing pregnancy rate. This is what meta-analysis suggested at that time. I would like to rapidly mention just another study that has been published later in 2008 is a large prospective randomized trial performed in the, in the Nordic countries, and again, patients that were considered as good prognosis patients were randomly allocated in a group stimulated only with recombinant FSH and a group receiving recombinant LH, and again, this large prospective randomized trial confirmed that, please just take in consideration the last line, that there is no difference in terms of live birth rate and ongoing pregnancy rate in patients supplemented with recombinant LH. So this confirms what I can consider, I don't know the reason why, what I can consider the first take-home message of today, that overall analysis of studies demonstrate that LH activity in a young normal gonotrophic patient with a normal ovarian reserve do not increase pregnancy rate, probably represent an adjunctive cost which is not justified. So let's move to other population, and an important question is if adding LH in a patient with reproductive, advanced reproductive age can increase. The question is always pregnancies. And in this case, I don't know, probably it's not working this. Oh, now it's okay, perfect. And what is the rationale? If we consider what I said before, that LH is crucial in sustaining FSH in more advanced stage follicles, this is because this cooperation is sustained by a lot of local paracrine activities that in senescent granulosa cells can be less efficient. So with aging, probably the lack of LH is less well compensated by the FSH monotherapy. This is just the rationale justifying this kind of studies. So we have more evidence here. This is a study by Peter Humayden that has been published in 2004. And please consider that patients were randomized to receive FSH monotherapy or FSH plus recombinant LH. In the overall analysis, the study did not demonstrate any difference in terms of pregnancy rate between patients treated and untreated with the recombinant LH. But what is intriguing is that if we consider only the population of above 35 years, the implantation rate was increased significantly increased in patients receiving LH supplementation. It doesn't happen, it didn't happen in younger patients. So above 35 years, the LH supplementation was effective in increasing implantation rate. In younger patients, it was not useful, didn't change significantly the implantation rate. This kind of observation has been confirmed in another study. This is the first prospective randomized trial in which patients between 35 and 39 years were treated with recombinant FSH alone or randomly allocated in a group receiving recombinant LH plus FSH. And despite the number of observations is relatively low, and the p-value is not so impressive, but this is the first study that has been performed in this subset of patients directly, 35, 39 years, and here they proposed a significant increase in both implantation rate and live birth rate. Anyway, I can understand that such kind of evidence is not so much robust, but just to propose this meta-analysis that this has been published a few months ago in fertility and sterility, considering all the trials, comparing recombinant LH and with recombinant FSH with FSH alone, and the overall results suggest a statistically significant increase in ongoing pregnancy rate in patients treated with recombinant LH in age between 35 and 39 years. So the second take-home message is that there is initial evidence sustained by randomized trial, at least one meta-analysis, that adding recombinant LH in patients above 35 years increases the chances of a pregnancy, at least the ongoing pregnancy rate. This is the second point. Third point is the concept of hyperresponders. This is, I just need for a few minutes your attention. Please consider this is the definition of poor responders according to the new ESHRE criteria. Please consider that when we define poor responders, two kinds of elements are considered. The response to previous stimulation, meaning that a poor responder is a patient who had few eggs or who showed low estradiol levels at the end of the stimulation. And for the first time in the definition of a poor responder, the ovarian reserve is considered. So at the end of the history, a poor responder or a patient at risk for poor responder is a patient with a reduced ovarian reserve. This is a crucial point because this concept is totally different from the concept of hyperresponders that we tried to define. Just an example from the clinical practice. This is a schematic representation of a standard GnRH-LOM protocol in a young normogonadotrophic patient with a normal ovarian reserve. What happens in the clinical practice is that if we start with adequate dose of recombinant FSH, in most cases, about 85% of cases, we usually do not modify the starting dose, or sometimes we reduce the starting dose on day 5 or day 8, meaning that if we have a normal ovarian reserve and the starting dose is correct, usually we do not administer more than 2,000, 2,500 international units as a cumulative dose of a recombinant FSH. In a small percentage of patients, something strange happens, mainly if we talk about standard GnRH agonist protocol, is that during stimulation, the initial response is very slow, despite patients have follicles. They have a lot of follicles in the ovary. The problem is not reduced ovarian reserve, but the estradiol levels remains low for 7, 10 days. And so what do we usually do in the clinical practice? We increase the FSH dose. So at the end of the history, these patients are normal responders because they have a normal number of follicles and eggs, but the problem is that these patients have and required a higher dose of FSH. So another concept that I would like to introduce is that an hyperresponder is a patient with normal ovarian reserve, normal anterior follicular count, normogonadotrophic, young, that has a normal ovarian retrieval, but requires higher doses of FSH than expected. So she just have a hyposensitivity to exogenous FSH. And this is what we demonstrated in some studies in the past with Anna Pia Ferrarette and other studies, is that in such kind of patients, if you add LH during stimulation, you can increase the implantation rate and the pregnancy rate. So this is a crucial point for me, because I have never said that recombinant LH increases the pregnancy rate in poor responders. I have never talked about poor responders, and I would like this kind of context is important for me to clarify, because in several meta-analyses, our studies and the study by Anna Pia Ferraretti were reported as studies in poor responders, but poor responders are totally another problem. In fact, if just to mention, there is a recent study by Alberto Revelli, but there are a lot of studies demonstrating that if you use recombinant LH in patients in real poor respondents, meaning patients with reduced ovarian reserve or dramatically reduced ovarian reserve, no miracle can happen. This is an important point. So this is just to conclude this part, that randomized controlled trial and at least very weak, but anyway, a meta-analysis demonstrated seems to suggest that in such kind of patient, adding LH is well performing and better than just increasing FSH. What is important, if you pay attention to this slide, what I said, that the patient with the normal ovarian reserve that have a slow response to FSH can have an improvement if you add LH. So someone can hypothesize probably this patient have very low endogenous LH circulating levels. That's not true. There is an increasing body of evidence clearly demonstrating that the levels of LH are not predictive of LH requirement during stimulation. In our series, for instance, the patient who had low LH levels did not require any LH supplementation. And conversely, patients with high levels of LH during stimulation in some cases benefited from LH supplementation, meaning that probably it is not important circulating immunoreactive levels of LH, but what is important in not in all, but in several hyperresponders, probably is the bioactivity of endogenous LH. And this is the hypothesis we explored, that patients with normal LH levels, but benefiting from LH supplementation, probably had and less bioactive polymorphism of LH. This hypothesis was tested in our unit in collaboration with the unit of Peter Humayden, and we focused on a very common polymorphism of LH, which is called V-beta LH. In Italy, the allelic frequency is 14% of this polymorphism, and this is a less performing, a less working LH. It is probably 80% of biological activity of wild-type LH. And what we found is that in a first retrospective analysis, if we take normal responders, patients who had no problem in terms of number of eggs, who had at least 5 eggs retrieved, but we just stratified this patient according to the cumulative dose of FSH received, we can appreciate that the overall incidence of the variant in our group was 14%, but if we consider patients who had low doses of FSH, and that we called here normal responder, no polymorphism was found. If we consider population with normal response in terms of number of eggs retrieved, but who received very high doses of FSH or very long stimulation, the frequency of this polymorphism is 32%, and this has been confirmed in a second series performed in 200 cases from Denmark by, I analyzed samples that I had from Peter Humayden. So we have 60 patients in the first series, 200 in the second, and what we can say at this moment is that carriers of this polymorphism require higher doses of FSH and probably benefit from LH supplementation. So just a few words about antagonists is just to consider that until 2007, there was no evidence that adding recombinant LH in antagonist cycles could increase the pregnancy rate. These are historical studies in the meta-analysis of Griesinger. So at that time, the evidence is adding LH activity in an antagonist cycle do not increase pregnancy rate. But please consider that in all these studies, 75 units of recombinant LH were given. There are no studies in literature that addressed the point if we give 150 or 225 international unit of recombinant LH, what happens? We only have an experience in this, but the end point was the number of mature eggs, and what we can say is that with 150 international units, the situation totally changes. So if we consider that meta-analyses are crucial for understanding the future line of research, I invite me and everyone to consider the possibility of repeating studies with antagonists and LH, considering higher doses of recombinant LH. So let me conclude. What we can say is all the take-home messages we had in the several parts of the presentation. We can say that randomized control trial and the least huge meta-analysis confirm that giving exogenous LH, at least in form of recombinant LH, in all patients is not useful. But there is evidence, randomized control trial and one meta-analysis, that women that have hyposensitivity, normal, good prognosis patient with normal ovarian reserve who have a hyposensitivity to FSH do benefit from LH supplementation, and this probably is based on genetic or other kinds of pathogenic mechanism. We don't know it at this moment. An increasing body of evidence suggests that in patients between 35 and 40 years, the recombinant LH supplementation can be useful to increase pregnancy rate, and there is no evidence that recombinant LH is useful in patients with a reduced ovarian reserve. So I would like to thank Andrea and all the people that support research and supported this kind of research in the last years in Naples. Thank you very much.